65-year woman patient, echocardiogram. Parasternal long axis view. Take a shot. In this view we're gonna see that we have no pleural infusion and pericardial infusion. We can see descending aorta. It's not very large, it's normal. Then we go to ascending aorta. It's gonna be not more than ascending aorta 36. We have 32 millimeters. That's normal for a woman, for female. Now we're gonna see sinotubular junction. It is less than 33 millimeters. That is normal. And aortic sinus. Aortic sinus. We're gonna measure, and it is less than 37 millimeters. That is normal. Then we're gonna observe in zoom mode an aortic valve. We see aortic valve is slightly thickened in the basis, but it looks quite normal. Take a picture with color mode. One more time without color and color mode. Then we're gonna measure the LVOT, left ventricle outflow tract. This is a very important issue, and we're gonna measure it a couple of times to be more accurate. In female it's about 18 millimeters. So aortic valve does not have any leaks and looks like not to have aortic stenosis. Then we're gonna zoom mitral valve. Mitral valve is opening quite good. We see motion of anterior leaflet. There is no tenting, so we have not normal, but we don't have a mitral stenosis. What do we have here? Slightly calcified mitral valve annulus. This is here, but it's quite good functioning. We have no mitral regurgitation. And then we're gonna measure left atrium diameter. Left atrium diameter from sinus perpendicular, and we see left atrium diameter less than 42 millimeters. This is normal. Next step, we're gonna take a clip of left ventricle. I remind you, this is the still parasternal long axis view. Eyeballing left ventricle is good, have a good systolic function, and it looks like it has no hypertrophy. We see anteroseptal wall and posterior wall, and they both are not hypokinetic. We see a good ejection fraction, and now we're gonna measure it. We have a diastolic frame. We're gonna measure interseptal wall and left ventricle diastole and posterior wall. Then we pass through to Systolic frame and measure systolic diameter, and we see we have no hypertrophy and no systolic dysfunction. Then we go to observe right ventricle. Right ventricle is rather less than left ventricle. This is a good sign. And it has diastolic diameter less than 35. Right ventricle outflow tract proximal is less than 35. We can measure right ventricle anterior wall thickness, and it is less than 5 millimeters. And then we go to observe pulmonic valve. Pulmonic valve is not thickened. Take a picture. and this is the right ventricle outflow tract. We can measure it right here. And it's less than 27 millimeters. Then we're gonna measure right ventricle outflow tract pulse wave Doppler, and we trace it. And remember, it's VTI and stroke volume. Stroke volume is about 50 millimeters and VTI is 20.9, and pressure gradient is maximum pressure gradient PG max 48, and velocity, peak velocity is 48, and pressure gradient is maximum 1 millimeters mercury. This is about normal outflow tract velocity, and then we measure PV max. PV max is not elevated, 4 millimeters big pressure gradient, and we see a slight pulmonic regurgitation, and we can measure PR, and it's not elevated, only 5 millimeters mercury. So we can make a little conclusion that there is no pulmonic stenosis. Also, we can see here we must not see here any flow in diastole. We have a anechoic pulmonic artery in diastole, so we can be sure that there is no opened arterial ductus opened. And then we gonna check out aortic root, aortic valve in transverse view. We see leaflets of aortic valve are not thickened, maybe slightly thickened, and it opens quite well. In this view, we're going to exclude interventricular septal defect, membranosus septal defect. We can see that there is no any septal defects. I forgot to observe right ventricle right atrium in long axis and right atrium in short axis view, and we want to see tricuspid regurgitation to measure right ventricle systolic pressure. But unfortunately we do not have good tricuspid regurgitation, and we do not sure that there is no pulmonic hypertension. And then we're gonna see left ventricle in short axis, mitral valve, muscles, this frame is very important to trace endocardium, to measure in myocardium mass index. We trace epicardium and endocardium, and then in 4-chamber view we gonna measure length of the ventricle to measure this myocardium mass. Here we see tricuspid regurgitation. It's much better, and we can measure, and we can be sure that there is no pulmonic hypertension now. Then we go to apex. I didn't catch the apex. Apex is not hypokinetic. And now we go to apical view, adapted to see right ventricle and right atrium. We're gonna measure right atrium, and it width not more than 4 centimeters. Then we're gonna measure tricuspid septum excursion. And it's not less than 17 millimeters. So right ventricle systolic function is quite good. In this view we can measure right ventricle at the middle and right ventricle at the base. At the middle it's gonna be less than 35. Here is 21, 28, and in base it's gonna be less than 41, and here is 33. It's normal. So we can make a little conclusion that right ventricle has good systolic function, is not dilated, does not have a hypertrophy, and right ventricle, right atrium is not dilated, and we have no pulmonic hypertension. Then we're gonna go to apex mode, 4-chamber view. Take a picture. Сделайте, пожалуйста, вдох. Чуть вдох, стоп, выдох, стоп, стоп. Дышим. Что-то хотели?
Пациент просит его принять после этой пациентки, которая на 2 часа. Очень спешит. Сможешь?
Пока не знаю.
Ну, передвинуть его до обеда.
Пока не знаю.
Сидит.
Now we measure end diastolic volume and end diastolic length of left ventricle, and here we can see that myocardial mass is 90 grams, that is normal, and myocardial mass index is less than 95 grams per square meter. We have no any left ventricle remodeling, and in 4-chamber apical view we can see the left atrium. Left atrium seems not to be elevated and not to be enlarged, and we can trace it. I'm gonna little optimize. Optimize image to not see auriculum. I don't satisfied to this view. This view would be much better. No foreshortening, but a little smoky. Okay, so now we're gonna see the 2-chamber view. Take a clip picture. Measure the 2-chamber view diastolic diameter, systolic diameter, and we can be sure that systolic function is not impaired. And now we're gonna measure diastolic function. First, we take tissue Doppler mode, switch on, pulse wave Doppler, and take a picture of septal E prime, septal mitral annulus, septal E prime, and we can see that is much less than 7 centimeters. This is actually 5 centimeters. Okay. Then we go to lateral. Lateral wall. Lateral E prime is much less than 10, and it is about 5 centimeters. And then we go to take a pulse wave Doppler of left ventricle inflow tract. And we gonna measure mitral valve E and A, and we can see that E to A ratio is less than 0.7, so we can be sure that we have impaired relaxation, diastolic dysfunction grade 1. And 3-chamber view. No hypokinetic walls. Again, 4-chamber view. And now I want to take a picture 3D. Nie дышать. Дышим. And now we're gonna measure 3D dynamic heart model to obtain left ventricle systolic function and volumes of left ventricle and of left atrium. Yeah, it's not optimal because we have poor echo window. Ну-ка, чуть-чуть наклонитесь. One more time. Укладывайтесь на спину, пожалуйста.
На спину?
Ага. Poor echo window. Well, this is quite to be true. Okay. Then we go to suprasternal view to measure descending aortic flow. Oh, I forgot to measure aortic flow. And it is not elevated, less than 1.7 centimeters per second. And LVOT is not elevated. It's quite equal stroke volume in right and left ventricles, is about 40 millimeters, and we can see this stroke volume by LVOT and stroke volume by B plane. Not very equal, but about the same. And now we want to measure subcostal view, to measure the IVC, and maybe it's not an IVC. Сделайте глубокий вдох. Дышите. Seems to be enlarged. No, this was the descending aorta. Yeah. This is the descending aorta. It's going to be less than 25, and IVC, we want to see it less than 21 millimeters. And subcostal view. Сделайте вдох. Subcostal view. Take a picture of interatrial septum. We do not have. Дышите. We do not have any interseptal, atrium septal defect. Atrial septum defect is not detected. Все, можно вставать. Одну секундочку.